Welcome everyone to iCHOM's webinar series. Thank you all for joining us for another exciting session where we'll be hearing from CIMAS on their health outcomes measurement journey for diabetes mellitus. My name is Umanga De Silva and I'll be moderating today's session. As we make our start today and are joined by more and more people from across the world at our webinar, we'd love to hear where you're joining us from. So please do feel free to write a quick introduction in the Zoom chat and connect with others attending today, just in terms of the country and your name, just so we can see who's joining us today. We'll also be using the Zoom Q&A function all throughout the webinar, and we'll have some time for questions at the end of the session. So please do feel free to use the Q&A function all throughout to let us know of any questions you'd like asked of our speakers. And if there's any questions that you see come up, asked from other audience members that you would like to see answered, you can also upvote them to indicate your interest in those questions. Next slide, please. Great. So before we do get started, I want to just give a quick reminder that we're fast approaching the iCHOM annual conference, which this year is being held from September 29th to August 1st in Dublin, and we would love to see you there. We have over 600 attendees joining us this year with over 80 confirmed speakers who are leading a lot of really thought-provoking workshops, panels, and other sessions for which the theme this year is From Vision to Action, Real Results, Real Change for Patients. So really a huge focus on what value-based healthcare actually looks like in practice, with sessions really focused on those practical examples that you can really learn from, as we'll also be hearing today. So there will be a lot of opportunities for networking and learning, and so we look forward to hearing more from leading organizations implementing value-based healthcare to learn more about the challenges faced, the lessons learned, and the results that they've achieved. So you can follow the QR code on screen here, which will take you to the iCHOM website to learn more about the conference or to get your tickets, which are currently being offered through an early bird sale that lasts until July 31st. So it'll be a great time for you to register. So today's webinar will focus on the implementation of the iCHOM diabetes set. If you're interested in learning more about the set, we invite you to follow the QR code that you see on screen here to take you to the iCHOM diabetes set page. And there you can access our freely available resources that give you all the details you might need on the different components of the set and the information you would need to implement it as well. But let's proceed with the topic of our webinar today. So we're really excited to be joined by two expert speakers from CIMAS in Zimbabwe. So we have Dr. Travolta Mushayamano, who is the head of clinical services. Travolta is a medical doctor and oversees the CIMAS network of clinics. And we're also joined by Mr. Foster Ketwa, the Chief Information Officer. Foster is responsible for and is really passionate about digital transformation at CIMAS and has been involved with the initiative we're discussing today since its inception. So CIMAS is Zimbabwe's leading health and wellness service provider with a strong presence both as a healthcare funder and a service provider through its own network of clinics, and they were established in 1945 and now support over 200,000 paying members with services spanning medical aid, preventative health, lifestyle interventions, and clinical care. And they have a really clear and powerful purpose, which is to inspire healthier communities. So in response to the growing burden of diabetes in Zimbabwe, CIMAS has committed to advancing value-based healthcare to ensure clinical efficiency, patient focus, and treatment quality and cost management. And as part of this, they've taken a really crucial step by implementing the iCHOM diabetes set to better understand actual outcomes and costs of care. And this work has been supported by the Nordic Healthcare Group, who is an iCHOM implementation partner, and they are a leading advisory, insights, and research firm who provide global services for value-based healthcare implementation. So together, CIMAS and the Nordic Health Group have really developed a strong foundation for collecting and using outcomes data and for visualizing this data to use it to inform clinical and management decisions. So this session today will provide a closer look at the progression of this work and the lessons learned from implementing the iCHOM diabetes set. So I'm really excited to hand over now to Travolta and Foster to take us through their journey for outcomes measurement in diabetes care. So over to you both.
Thank you, Umanga, for the introduction. We're quite pleased to be here to be sharing the CIMAS story. So we'll start from here. But before I start, I just also want to thank ICHOM for giving us this opportunity to share our story with the world at large, highlighting some of the successes that we have had with the diabetes outcomes measurement and some of the lessons that we have learned, as well as how we are taking this project forward. We believe quite a number of people are also on the same path, so we look forward to sharing the knowledge, sharing how we can take this going forward. So just another quick look at who CIMAS is. You gave a good introduction to who we are. That's our structure that we are showing there. So we are an integrated healthcare services company. We are a payer as well as a provider of healthcare services. So you'll find that on the screen. We do have pharmacies, hospitals, ambulances, you name it. So since we were formed in 1945, we have gone through 80 years of growth. 2016, that's where we had our newest baby in terms of wellness services that is shown there, named IGO. And since 2023, that's when we went into healthcare services through hospitals or tertiary care. So I won't spend much time on that. I'll go straight into why value-based healthcare at CIMAS. So I think the issues that affect us affect everybody. I think from the training that we have had in the past through ICHOM, as well as practical experiences that we have had through sharing knowledge with other peers, fee-for-service has been a challenge in that it presents quite a number of issues for both payers and service providers. But on the screen there, I showed just a few. One of them is overutilization and incentives misalignment, where people are motivated to do more instead of trying to look at outcomes to say, what is it that the patient is looking for? How best can we maximize these outcomes instead of trying to do as much as possible to raise money? And we see this as an incentive with some of the healthcare service providers. But for us to have some kind of alignment, we believe value-based healthcare is the answer. We have seen escalating costs. I think we will speak to this at length. There's been also fragmented care and lack of accountability. So we are not saying with the outcomes measurement that we have done for diabetes is the answer for everything. But we believe fee-for-service will remain some of the things that we do offer. But our direction and strategy at the moment is to ensure that we start moving or focusing towards what value-based healthcare can do for our business. Now, some will ask, why did you start with diabetes? You find that there are quite a number of outcome measurement sets that are there, and some of those conditions, we proactively manage them within our business. But when we looked at diabetes, we believe that we currently, at the moment, is one of the top 5 conditions where we pay quite a bit as a payer. And those costs, when we have been monitoring them over time, they've been growing. And the other reason is foundational support. So we have had quite significant, we were having significant support from Nordic Health Group in terms of the support that we needed to have to come up with the strategy that we implemented for diabetes outcomes measurement. And we also had support from Novo Nordisk, who supply us with insulin. So they came with quite a few standards that helped us to get started on this journey. Then the other reason is data availability. We see that from the claims data that we have been managing, we do have quite a lot of data that we have. So it also was a good reason for us to get started on diabetes, as well as just the organizational readiness on its own. This just demonstrates the costs that we have incurred since 2020 to date. We started actively implementing value-based healthcare in 2023 for diabetes. In the graph there also demonstrates the impact our initiatives have had. The graph on the left just demonstrates the costs from the world at large, that this is not a burden for us only. Our context is not unique. We have been seeing this from our literature research as well, that costs for value-based healthcare, for diabetes are escalating all over. Now, when we identify diabetes as the starting point, we believed that we needed to have some kind of an implementation approach. So in our business, the CEO as well as the senior management introduced value-based healthcare, and it started to be introduced to everybody within our group. So we didn't struggle much with executive buy-in because they actually were instrumental in introducing this in our business. So soon after that, we started identifying the key departments that we needed to involve. So you find that according to that structure that I showed earlier, clinical services, medical laboratory, IT, managed care, these are departments within our business that we then put together to come up with some brainstorming sessions in terms of what is the best practice, how do we take this forward? And we set up some committees to help drive that strategy. We came up with a strategy for stakeholder buy-in right from the onset. So those are the areas that we identified just as a way of ensuring that we start the project from a position where we are ready to implement with results. So after the setting up of the committees, we came up with an implementation framework. So this basically was our strategy to say, how do we take this and what is our plan for ensuring that this doesn't die as soon as we introduce it. So initially, the task that we had was to identify the outcome measures. And this is where we used the diabetes outcome sets, measurement sets, and identified those areas that we had data for and areas that we needed to identify additional data so that we can be able to have comprehensive data so that we can take the project forward. And this was led by management and clinicians. And the second step in that approach has been the data collection, coming up with a comprehensive initiative where we included manual methods where we call our members who are on diabetes program so that they can give us the information on prompts, and as well as coordinating information from our various systems so that we can then combine the information from our patients as well as what we have been collecting via the claims management processes. Then after that, we went into a phase of data visualization. So this is where we started ensuring that we are doing trend charts, as well as demonstrating the impact of every activity that we have been doing so that both clinicians, management can be able to see the impact of the activities on the ground so that everybody can be able to see how their effort is contributing to the ultimate shared goal. Then lastly, we had a plan for continuous improvement. After having done all this, how do we ensure that the program for diabetes continues to move forward with confidence? So this demonstrates in more detail the data collection that we have been doing, where we collect prompts from our patients, as well as claims, good data from our claims data, where we combine all the data into a unified data warehouse. So this was in line with our overall digital transformation strategy, where we looked at how is technology going to enable our project. How are people going to be involved? So hence we mentioned the issue of change management earlier, as well as what are the processes that need to change in the business so that they can support a value-based healthcare. In terms of our visualization, it was very simple. We looked at basic things like we want to allow clinicians to filter through the data and what are the parameters of interest. And these are tied to the outcome measurement sets so that whatever filtering, whatever slicing and dicing of data happens, it's supporting what the clinicians are doing. Then we also looked at ensuring that the data is unified, the dashboard is unified. This basically means we take data from outcomes measurement, the prompts. We also take data from the cost side of the business so that we can then see how those are interacting with each other. What is the impact that we have had on all fronts? Then we also looked at ensuring that the data visualization is speaking to the ICHOM outcome measurement set for diabetes. This has been our approach for continuous improvement, where we had processes that we defined to ensure that patient interaction doesn't remain the same. I think you would agree with me that as soon as you have got insights, you'd want to make sure that you apply them to business. So we have got a framework where there is a continuous improvement process where all the information that we gather, we apply it to our day-to-day processes. We ensure that we don't get insights that sort of like get wasted because you don't get to apply them in your day-to-day work. We also looked at things like in terms of our management system. How do you ensure that performance management and what the additional work the clinicians are doing, how do these two things tie to each other so that we have a system where we are learning something, we are also in the process of applying our learnings. We go back to experiment, we come back and apply the learnings going forward. And this has been feeding our research going forward in terms of what we can do next. As Travota will show in a few minutes, you realize that the outcomes measurement that we've done for diabetes at the moment, we are now able to benchmark at patient level. We can be able to compare like for patients on the same program, which interventions have given us the best outcomes and which interventions need to be improved. We can also benchmark at physician level, which doctors have been giving us the best outcomes, and they can share with others in terms of what is it that they've been doing, which gave them the best results. We also benchmark at clinic level, hospital level, where we can compare outcomes because, like I said earlier, we are a diversified group. But we haven't started doing the regional benchmarking where we could benchmark from various regions regions, as well as at the national level and international level, which are steps that we believe we would be doing going forward. And that does just demonstrates the continuous improvement cycle where we visualize outcomes, we identify the best practice and implement the operational changes that we'd want to do. So Dr. Travota will take us through the actual dashboard. Probably I will just warn you that it's a lot of detailed numbers in there because it's the actual dashboard to demonstrate how this approach that we had done is given us the results that we have today since we launched the outcome measurements. Over to you, Doc.
Thank you, Foster. Let me start by thanking ICHOM again for granting us the opportunity to present our journey and experience. Now, this is our end product, what we came up with. This is just the cover page. And as you get into the dashboard, you realize that we intend to grow beyond just diabetes. And already we've incorporated hypertension into it, although we are not going to be focusing on that. Today's talk is mainly on diabetes, which we have tried to really smoothen the journey. So you then get to the next page by clicking the next tab, and what you get is this. So this is really a consolidated picture of the diabetic patients we are taking care of. In total, we have 1,624 patients, and these are some of their parameters. In terms of HbA1c, you find that just over 52% of the patients actually have poorly controlled diabetes, above 7%. Blood pressures, average 133, diastolic 78. And this is just a demographic picture showing the bulk of our patients really are between 45 to 64 years of age. Now, we have HbA1 bands, again, showing that there is quite a significant number of patients who have poor control. Only about 500 out of 1,600 actually have HbA1cs that are on target, and between 7 to 8.5, about 400, and 8.5 to 10, 485, and even patients that have HbA1cs above 10%. We also have some that we don't actually have HbA1c results in this dashboard, partly because some of them go to seek the tests from third-party providers, and exchange of data between us and third party has always been a challenge. So you find that 265 of them really don't have any HbA1cs that we captured in the system. Other concerning parameter we looked at was the BMI. So you can see that majority of the patients are in the overweight and obese region. And again, we have some that do not have parameters captured. But the likelihood that majority of them in this region also are going to fall under either overweight or obese. So this is a serious issue, and I also believe it's not unique to us, but world over. Now, in terms of patient-reported outcomes, we have implemented a paid score, which is internationally standardized tool. Again, acquired this through ICHOM, and this tool measures scores up from 1 to 100, and above 40 basically signifies that there is really it's an outcry, and there is significant distress associated with managing diabetes, and below 40 is acceptable. So our current average paid score is sitting at 33, which is an acceptable diabetes distress. So in terms of proportions, 64% of the patients scored the paid survey into the accepted diabetic distress range, and only 35% have significant distress. And when we looked at this data, what was actually surprising was that those that seem to have their HbA1cs under control seemed to score much higher than, for example, people who are in this band whose HbA1cs are above 10. And of course, the data is still coming in, but it's something we noted, and perhaps just points to the fact that patients who are doing so poorly really sometimes don't care much about the condition itself, so they score low on the survey. Now, the paid survey itself, this is the tool, and it comprises of 20 questions, and where the patient is going to be just basically ticking and scoring, and it then calculates the score based on there's an algorithm to calculate and bring the total up to 100. Now, I also must just say the response rate for this paid survey has really been quite poor. At the moment, we are sitting at just over 7% response rate. And I do understand the patients. They really have no time to be completing surveys. So I understand them. I mean, recently I've been going through the value-based healthcare training with Scott, which also had a survey, end of course survey, to evaluate the course. And I still haven't completed that survey. And I understand myself. So the point is, I do understand the patients, and our 7% response rate. We tried to come up with a plan to increase that uptake. So we developed a QR code, which we put in our pharmacies. So this is one of our pharmacies. And when a diabetic patient comes to get their medication, then the pharmacist can also just implore them to scan the QR code while they are waiting for their medications, and they score the the paid survey, which then feeds directly into our dashboard. Then in terms of the parameters we've been tracking, again, the averages I've already showed the blood pressures, systolic, diastolic. The average HbA1c at the moment is 8.72, which is quite high as well. Now we can track each clinic through all those parameters. And what we noted, which was interesting, this was a very early observation, that one of the clinics which had a claims ratio which was the lowest, 92%, which is basically a fraction of what the diabetic is spending versus their contribution, their premium. And so we find that all the clinics are above 100%, with an average of 122%. That was in 2023. And so if a diabetic pays $100 as a contribution, they go on to spend $122. And so basically diabetics are surviving on the solidarity and goodwill of the other paying members. But what was interesting was that the one clinic which had a claims ratio under 100 also happened to be this clinic with the lowest HbA1c when we compare clinic to clinic. And so this builds the hypothesis that the better the HbA1c, the lower the cost of care as we go forward. And as we track this data, that is the hypothesis we are trying to prove and back up with actual data. Now, the algorithm which pulls the HbA1cs, when we started in 2023, but it had the ability to track back, pulling results from as far back as 2020. And this picture was interesting for us because we noted that there seemed to be a flare around July 2021. And this happens to have been the time out of the pandemic in 2022, it seemed that we started having better control. However, even after the COVID pandemic, we also noted that there was another spike. And we think that this is really COVID which unmasked some of the diabetes. That's been scientifically proven that COVID had an effect of unmasking. And so we got a lot of people who were diabetic for the first time after having had COVID. Now, the cost, that's the other thing we are tracking. So when we started, this is 2023, and then 2024, and this is year to date. So you can see that what actually happened when we started outcomes measurement is that the cost went up. It almost tripled in 2024. And currently, the projections also show that the cost is going to be much higher than it was in 2023. And we think it's in keeping with transitioning into outcomes measurement. When you start, your cost usually is going to go up because you are now offering much more, you are doing much more to try and control, and that cost is going to go up. But hopefully, as you progress and control the HbA1cs better, you end up with significant savings. So that cost, we also monitor where exactly the diabetics are spending. So you find that we significantly have a lot of expenditure in pharmacies where they get their medications, followed by hospitalization and pathology tests, which is their routine blood tests, kidney function, and so forth. So that's the bulk of diabetic expenditure for the patients we are following up. What was interesting for us was that when we then look at the ones that we are following up versus the other patients who are diabetic on the insurance side, but who are not in our program, what we noticed was that, you know, the hospitalizations for those who are not part of this dashboard was much higher, 17%, compared to the hospitalizations for the patients who are under our care. So we really think that we have some difference, and over time, the savings we're going to get will outweigh the current spike in the cost. Now, we then drilled further down onto the medications, seeing that it's where the diabetics spend more. Now, the graph shows the type of medications the diabetics are on, and Galvus metformin being on top, Novomix is an insulin, then Ranofage, another oral, Glimulin, another oral, dapagliflozin, also another oral. And what was interesting here is that, you know, if you combine just these orals, you'd go up to nearly 350,000 US dollars in expenditure. And yet, what's been proven to have the biggest impact on HbA1c is Ranofage, and that impact is just about 2% change in the HbA1c. The rest of these orals, they range between 0.5 to just under 1% reductions. And so with that pool of patients that have HbA1cs of 10 or between 8.5 to 10, even if you combine all these 4 oral agents, you are still not going to get to target of under 7%. And I know that Big Pharma is not going to be happy with me mentioning that, but really there isn't much value in the orals when you really look at how much they alter the HbA1c. So we've been trying to transition patients to insulin, because insulin doesn't have a ceiling in terms of its impact. It's not an easy journey. See that only 24% of the patients were on insulin, whereas 75% were on the orals, as highlighted. Now, the initial cost was showing the entire cost of care, but we were also tracking the actual ratio, the claims ratio related to the actual diabetic. So when we started, in 2023, the claims ratio was 124, as highlighted, and over as we go, it seems that the claims ratio is starting to go down, which we are hopeful that we're going to maintain this trend. The average over the entire period has been 116. So we are still spending more than their contributions. And noting that the medical insurance is not an infinite resource, we really need to keep that on track and come under 100%. Another parameter which we thought would show is that that claims ratio also has got a quarterly variability. And we find that in the first quarter of the year, in the second quarter of the year, we tend to have very high claims ratios. And as the year progresses into the third and final quarter, we start having much lower claims. Right. So with that data, our next steps? We have a department called the IGO, and IGO is really our wellness hub, which is responsible for diet coaching, healthy lifestyle, exercise, and so forth. So all those members in the dashboard, we then refer them through to this IGO department. And the services they offer include the one-on-one coaching for the diabetics, doing their plan, their meal plans with the dietitians. They also created a WhatsApp group, a support group, where they share presentations, audios, and there are also peer-to-peer exchanges that are happening in the WhatsApp group. And they also meet on a monthly basis physically under the guidance of again the coaches to discuss some of the troubles and any health tips on diabetes. So this is an ongoing thing that we did. Then we also feel that we actually need a center for diabetic excellence because of the numbers we're seeing of HbA1cs greater than 10, greater than 8.5. So we identified a program for intensified diabetic care, which is being offered by the local university. And we have now enrolled 3 of our doctors in the program. And once they are done and certified, we hope to then bring them together under one roof and create a center for diabetic care. On the tech side, we have something which is in the pipeline being developed internally called the Health Sync app. And this digital transformation, as Foster highlighted earlier, it involves creating this app, which is going to have all these services integrated in one. So customized experience, chronic disease management, even gamification with rewards to the members. It's also going to be the tool that then measures our patient-reported outcomes, and hopefully will gain traction in terms of our response rate. It also offers medication reminders and timely refills, health risk assessment, educational content being posted on the app. We have what we call the Blue Zone, which is a network of service providers that we partner with to offer services at reasonable optimum prices. Then, of course, the benefit checks from the insurance side of things. So what has been the impact to date of the things we've been doing? Now, we haven't really been focusing on blood pressure, but just looking at the average, systolic when we started was 134. And now in 2025, the average systolic blood pressure is 132. So it has come down by 2 millimeters of mercury just by managing the diabetes itself and not really focusing on the blood pressure. So these are fruits we are getting indirectly. The same with diastolic blood pressure. You find that marginal decrease from 2023 to 2025. The PAGE score, we started implementing it in 2024. And at the beginning, our score was 33. And when we come to 2025, it is now 29. So again, a marginal decrease as the data is still coming in. But the major impact that we are really proud of has been on the HbA1c. Around 2024, that's when we really had organized ourselves and had done a lot of data cleaning, and the dashboard was now making sense. So we started tracking from then, and you can see that generally the trend has been a downward trend, and we are hoping that we're going to keep this because clearly there has been quite a difference just from outcomes measurements alone, which has allowed the HbA1cs to be better controlled without significantly changed guidelines or without much changes in the actual management, but just outcomes measurement and engagement of patients has achieved such significant changes in the HbA1c. And what has been the feedback from the patients? A lot of them really have been quite happy. So these are screenshots from the WhatsApp group, support group that we have. And lots of them have been sending messages signifying that they are quite thankful to be added to the platform. One of them said, hello friends, I've been okay. Sugar is controlled, blood pressure is good, and they've started walking for 30 minutes daily. It's all a matter of trying to change your lifestyle and eating habits. Remember, health is wealth. Nothing more important than your own health. Have a good day. So those are the kind of patient responses we are getting. And another one, so this one in particular is a patient who had gotten advice from another patient, so that we don't take credit for everything. So they were actually thanking another patient in the same platform. Thank you so much for the advice. My sugar has been drastically improved following your advice. So this is the example of peer-to-peer. Now, having the privilege of being your speaker today, I took the liberty to also showcase my local vernacular from one of the patients. So trust me, this is a good review. But what I wanted to bring to you, noting that it's quite a very long love letter, is the last statement here, which says, Mwari vanobetsera, isu tizvibetserao. And the literal translation there is that God helps us as we help ourselves also. And these are the kind of sentiments that the patients have been sharing. And the point is that they're now taking ownership of the condition and showing that the condition is theirs to control and through these all these platforms that we've created. So what have been some of the lessons we learned as we were on this journey? Some of them were highlighted through the presentation, the low PROMS response rate, which we digitalized the tool and strategically position it. Hesitancy by our clinicians to start insulin. This has been actually a big thing. We realize that it's not only the patient who is afraid of insulin and injections, but even the clinicians and the doctors. A lot of it is really irrational fear that a needle is going to affect the quality of life of the patient over time. So we did what we call the Buddy Doctor Initiative, which was supported by Novo Nordisk. And this training, the clinicians were taken to actually have dummy pens and be injecting themselves so that they get a feel of how it's like. And what that did is that it really demystified this whole fear that needles are painful, they affect the quality of life, because the current needles have been designed with such a small diameter that the quality and the pain really, the pain element is not there. Then internal resistance to change is also one of the challenges we face. When you introduce new tools, it's always difficult to get people on board. And internally, the good thing is that we were responsible for coming up and customizing the key performance indicators for performance appraisal. So integration of dashboard use into key performance indicators for our internal staff then became a solution to overcome some of the resistance we're facing. External resistance, much more tough to deal with, but we continue to have ongoing engagements with some of our externals to really educate them and get them on board on what the outcomes are going to do for us. Well, not for us per se, but for the patient. The other challenge, this was much early on, that you find that the data can be quite overwhelming and the workload can be a lot. And this was early when we started, because some of the parameters, when you go through the ICHOM sets, there really is a lot that you need to capture if you are to match the ICHOM standards. But our solution was really to just start slow, and even to start with just one parameter and follow it up. You'll still be able to come up with a story. Like what we did, we just have one prom basically, and then a few other clinical outcomes. And that enabled us to get onto the journey, to gain confidence, direction, and now are even motivated to go to other sets, hypertension, and so forth. Staff motivation and turnover, this is also another challenge, particularly for this part of the world. I think when we started, and now we have lost 2 key members, actually, who were very instrumental in pushing for the outcomes measurements that left the organization. And it really creates a gap and loss of continuity. It's not unique to the organization, it's nationwide and even continental. Loss of staff, and we try to come up with incentives. This is something we are planning. We haven't really actioned incentivizing people who are working on outcomes measures. The other thing we realized was that there was a significant mental health challenge among the diabetics. When we were administering the proms, we even identified one of the patients who was suicidal at the time. And they were quite young. It was a 27-year-old young lady. So when we identified them, we then engaged counseling services so that they are helped. So we then realized that there's actually quite a lot of mental health burden within the population. And so we needed to create dialogue with the patients in a non-clinical, non-confirmatory environment, like what we did, setting up the WhatsApp group, having group discussions in person, sharing peer-to-peer experiences. The challenge of data disintegration, again, this was early when we were trying to gather the data. A lot of the data was coming from multiple sources. And so currently we are developing what we are calling D365 and the Health Sync app, which I've shown earlier. This is really just to overcome the issues of data coming from multiple sources and they have just one single source of truth. Okay, so thank you so much for your kind attention. And as we always say at CIMAS, together we make a difference. Thank you so much.
Thank you both so much for sharing these insights with us. And with that, we move on now to the question and answer portion of the webinar to answer any questions that have been sent in by the attendees. So just as a reminder, if you have any questions that have come up while listening to this session, please do let us know in the Q&A box down below on your screen, and we can make sure that we ask any questions you share to Travolta and Foster to answer. So please do continue to use that function. But we do have a couple questions that have come in. So the first that's come in is, in your implementation of the ICHOM diabetes set, did you differentiate between type 1 and type 2 diabetes in your data collection, analysis, or reporting processes? And if so, how did this distinction influence care delivery or outcome interpretation?
Hey, thank you so much for the question. So yes, we did differentiate between type 1 and type 2. However, our type 1 diabetes was so insignificant. So majority of the patients were really type 2. I think up to 95% were type 2 diabetes. So the type 1 diabetes patients were also just incorporated into care program, but to compare outcomes, whether type 1 or type 2, we then didn't do that because the population of type 1 was really quite insignificant.
Fantastic. Another question that's come in is around for patients with poorly controlled HbA1c levels. So asking if you observed any correlation between glycemic control and the availability or consistency of the prescribed medication. So this is in relation to the challenges this attendee is asking about in relation to the pharmaceutical supply chain and the challenges in Zimbabwe. So how has medicine availability impacted patient outcomes?
Yeah, so I must say that the medicines are really available. As I said, we actually have a lot of support. Novo Nordisk does a lot of support, making sure that we have adequate medications. So we don't see patients being poorly controlled because they have no access to medications. So the medications will be there. A lot of it we think is lifestyle related. So even if a patient has medications, their lifestyle then determines how well they'll be controlled, and their adherence to actually taking the medication also compounds with the outcomes, which we think is the major issue with our diabetics than medications not being there.
If I can also come in there, Doc, just to buttress what you have said, that we also have invested in CIMAS distribution center as a business to ensure that the fill rates are quite high and we are quite responsive in terms of how we make sure that medicine availability is not a challenge. But the environmental issues, as mentioned by the person asking the question, are real. So there can be supply chain challenges here and there. But as a business, we have been quite robust and comprehensive in terms of how we handle supply chain and how we make sure that there is availability of medicines in our units.
Fantastic. Thank you both. Another question that's come in is regarding the changes observed in average blood pressure, HbA1c, and the PAID scores from 2024 to 25. Were statistical tests such as p-values used to assess whether these changes were significant?
No, so we are not applying any statistical comparisons. At the moment, we are still at a phase where we are just tracking the data. So statistical significance is not yet part of the comparison.
Great, thank you. So another question is around somewhere on the IT side. So what IT technical roles are the most essential for the success of your efforts?
Thanks, Imanga. So the approach that we took is to train internally. So we have got a dedicated team of data analysts who have been involved right from the onset so that they get to appreciate and understand what it is that we are measuring, the data sources that are relevant, how to ensure that the data pipelines from the various sources are put together to ensure that the dashboards make sense. Initially, we thought of the option of trying to also outsource some of the skills that we didn't have. But at the moment, most of the things that we do, we have been growing with the business in terms of the requirements of the various aspects of the technology that we need to utilize. Probably it's also just to reemphasize the learning point that has already been mentioned by Dr. Travolta, that we had to start with what we have. So sometimes when you want to make sure that we have all the skills, all the technology, all the platforms, it sort of like derails the entire program when you are rolling out outcomes measurement. So we were frugal with our technology. We looked at what we have, what it is that we can make use of, and the journey continues. The platform that Dr. Travolta showed in terms of the app, we have already built in some of the AI functionalities where some of the information The app can actually ensure that we go across all the data points. And if there's something missing from some of the people that we are constantly engaging for prompts, that information comes through to us. They can interact with the app in terms of through conversational AI in terms of what it is that they need, and the app can help with the locations of our services, the availability of some of the things that they need, just to ensure that we are also available for them 24/7. So we expect that as we buttress the skill in terms of the technology side, we also make sure that we provide those things going forward in a manner that ensures that we don't have any gaps as we also improve.
Thank you. So you mentioned in your discussion that you were having some challenges in terms of integrating data sources, but I wonder if there were also challenges in terms of the fragmented data systems and interoperability that you faced and how that might have been overcome.
Sure. So initially, when we built the initial dashboard, the clinicians struggled with some aspects of it because we'll take the data as it is from the source systems. So we went through a phase of data cleaning to ensure that the source systems themselves are feeding in clean data. So we went through that phase, and as you can imagine, the challenge of trying to pull together information from various sources, ensuring that every information that we are pulling from different sources is up to date. But that defragmentation, we believe, in as much as it still affects us to some extent, but through some continuous improvement and iteration on the processes, we believe we have sort of dealt with that risk to a large extent. But the initiatives that we have also started at the moment, we believe they are going to comprehensively deal with that, because we believe a platform where there is single source of truth is going to be the answer in some of the issues that we're facing, and we have already embarked on that trajectory.
Fantastic. Another question has come in asking about the role of continuous glucose monitoring in value-based health outcomes for diabetes. So I wonder if you can expand a little bit around that role of continuous glucose monitoring.
Yeah, so yes, continuous glucose monitoring is in fact the preferred type of monitoring, and it really is how the normal body works, where it's continuously monitoring the blood sugar and giving responses that are commensurate to your blood sugar levels. So that aspect is really what we would say the gold standard in terms of monitoring diabetes. The challenge is the cost at the moment, particularly for us in Africa. So the continuous glucose monitoring is quite costly, and some of our patients really cannot afford to be able to acquire that, and to be able to also do the necessary consumables that come with it. So at the moment, we don't have much of that, but surely as we continue our journey, I think we'll get to a stage where those things will be available, and we do desire that we get such continuous glucose monitoring devices over time, as they will become cheaper and cheaper as we go forward.
Fantastic. So I know that for a lot of implementers starting out, that getting started with data collection can be quite overwhelming to think about. So I wonder, from your experience, if you can talk a little bit about whether it was easy to get started with data collection, or if it's something that got easier over time for you.
It's something that got easy over time, naturally, as we applied the lessons. I'll tell you why. So some of the data that we had to collect is unstructured data, and some of the data which was easier to put together was structured data. So when you collect unstructured data, you need to make sure that you have got processes in place to make it make a whole lot of sense. So in terms of ensuring that we make it as easy as it is today, we had to make sure that we engage the vendors of the solutions that we currently use in ensuring that the way in which we do our data extraction, that data is readily available in a manner that is easily usable. Then we also had to look at other unconventional sources of talking to our patients. I think Dr. Travolta indicated the unstructured data that comes from platforms like WhatsApp. But that also limits us to the extent in which that data can be mined further for the continuous improvement. But we do make sure that the information that we get there is part of the information that we keep as a record for patients. Then we already had a clinical solution that we have that clinicians are used to and that they have been using over time. One of the things that we have been doing is to ensure that we buttress the electronic health record with information that we collect from all these sources, from the prompts collection, from the platforms, the groups that we have created, and the information that we also get from the mobile app that I referred to earlier, where we are incorporating things like wearables, where some of the information that we want to collect is something that we'll also be able to tap into just by virtue of you having consented to your data to be part of the information that will need to be part of this broader electronic health record. And that information, through iterations, it's now easier for clinicians to now identify the data that they need. It helps them in the conversation that they have with the patients, as well as ensuring that they identify further gaps that they will need as included in those sources. But in a nutshell, certainly it has improved. But when we started, we had to look all over the place so that we can have something that can start to make sense. And it's very important because it was reflected in the adoption levels when we started. When information was still being put together from various sources so that we can come up with a meaningful dashboard, the adoption levels across the clinicians who use this information was low, because we'd also imagine that the value that they could get out of it was also still trying to find its feet. But now we have quite a broader base of clinicians who refer to this, who also participate in ensuring that we see the same objective, see the same object. I mean, they apply their minds, ensuring that they are part of the team in ensuring better outcomes. But certainly now it's much better than it used to be.
It's fantastic. And sort of in the same vein of talking about data collection, I wonder what the patients' reactions were to filling out the surveys. I know you mentioned that even when we get surveys, it's a bit difficult to find the motivation to sometimes fill them out. So do you feel that patients understand the value of having filled out these prompts and what the data in them will be used for?
Yeah, thank you for that. I think it's a mixture of both. We do have patients who are quite proactive and knowledgeable, and I did come across one who was newly diabetic, and they came to ask me about the survey themselves, because they'd seen it somewhere and they really wanted to be part of it, because they were not yet in our dashboard. So we do have a crop of such proactive patients, but I think the majority really are more of what the general person will do, having challenges to really comprehend or creating time for such surveys, because they're just thinking it's one of those surveys that doesn't have any impact on their life or the care they'll get. So it's a mixture of both type of patient.
Fantastic. So you I wonder also about how patients were actually responding to the changes in care. And I know you received some really fantastic, WhatsApp messages in the community. But I wonder, as you were going through that transition, moving towards insulin, for example, or any other changes that you made, how patients were actually responding during those changes.
Yeah, so naturally you find that transitioning to insulin, for example, is really tough. Even for the clinicians, you have to gather your courage before you start telling a patient that I think we need to put you on insulin. So it's quite a challenge. And even the patients themselves also don't take it well until they start seeing the results. So that's where the peer-to-peer thing was really helpful, because we utilize patients who are already on insulin as peers to other diabetic patients who are not yet on insulin, to really show that it's not a difficult choice to make, and it doesn't really affect your life. But yeah, upfront, the changes are not easy to take up. And for us, because we're still actually on the journey and transitioning, we haven't quite captured what we would like to, because of such difficulties in the patients also accepting that that's the journey we want to take.
Fantastic. So I know you mentioned that the decision behind selecting the ICHOM diabetes set to implement that was around the rise in the global burden of diabetes, but especially in Zimbabwe as well. But I wonder if there's anything unique to your situation, or is it similar to what's happening in a lot of other countries in terms of that rise in diabetes?
Yeah, so the trajectory is the same world over. And it's basically the main reason why we embarked on it. I think the data also showed the obesity and overweight, and how significant it is. And it's really on the rise. So the trajectory of diabetes rising over time really was the reason why we chose diabetes to really follow up. And of course, the data being available. In our clinics, diabetic patients are about the third most common condition. There is hypertension, and then followed by diabetes. And I think the bulk would be like respiratory infections, acute infections. Yeah, is at the top, then hypertension, then diabetes. So we had a significant amount of data already available, and the proportions did make sense that would start with diabetes on that background of a global rise in the condition itself. Yeah.
Great. That's really helpful, and thank you for sharing that context. And in relation to that, we've had a question come in from the audience around strategies for prevention. So what are the most effective strategies for preventing diabetes and raising public awareness about the disease in communities?
Yeah, so the preventing diabetes really starts with screening. That's the first point. And for us, we do offer such screening. For our members, we encourage them to have an annual, we call it an annual wellness check, which is really part of their package of benefits on the insurance side. At least once a year, you'll get your full check, which then looks at how your blood sugars are, and cholesterol, all those liver and so forth. And the idea there is we want to pick patients before they are diabetic. If you can pick pre-diabetic patients, perfect. And lifestyle is a big thing. In fact, the type 2, as I mentioned, type 2 diabetes has got a huge lifestyle component to it. It's different from the type 1s. Type 1, well, it's a bit different story, but type 2, which is what is common and prevalent, has a big lifestyle. What they eat is what they become. And so if you capture it much earlier as pre-diabetes and then implement the lifestyle changes through the IGO department, which we showed, dietitians, coaches, exercise, and really preparing healthy meals over time, it can actually prevent diabetes. And not only that, there are even diabetics who have reversed their diabetes just from lifestyle. So they are diagnosed and they manage to do lifestyle changes over time, and that can reverse completely the diabetes to the point where they don't need the medication. So lifestyle, diet, exercise is a big component in both treatment and in prevention of diabetes.
Maybe to just add to what Doc said, on the lifestyle side, where we have been using, where our business on our arm called IGO has been quite instrumental in driving that change. So one of the things that they also do is to ensure that we tap into the environment in which you operate through what we call value partners. So in as much as we have got our own areas where people can subscribe to, be more active, participate in our programs during weekends, every day, we also have these value partners stepping in, providing some services which we ordinarily wouldn't probably be providing in-house. So like gyms, where we negotiate some very competitive pricing so that our members can get to access these, all in the effort of trying to ensure that the lifestyle story gets to be communicated to everybody in their best or their preferred ways of being physically active on a day-to-day basis.
That's great. Thank you both for sharing. So we have another question as maybe a good way to close us out, but I wonder from both of your perspectives, what advice you would give to other organizations who are interested in tackling their diabetes burden?
Okay, I can start. So for us, the key advice probably already covered in the lessons learned by Dr. Travolta. Usually it's about getting started with what we have, start small. One of the things that, when we were starting, it was very easy for us to say, we don't have this, so probably we have to hang in a bit and push the time to start a little bit further. So we had to ensure that we had to start with the technology that we had, as mentioned earlier. We had to start with the knowledge that we had. I think Dr. Travolta mentioned the ICHOM education training that we attended as a team recently, and some of our team members are still starting. We didn't have to wait for us to be at the perfect moment to get started. So we had to start with the knowledge that we had. Probably the greatest lesson out of that is to ensure that we have the necessary support from the key stakeholders. Our executive management supported this from day one. So it's also another advice that we could also offer to those who are looking forward to start, to say, encourage your teams, give them the confidence that they have what it takes to get started with measuring what they are able to measure. Sometimes people want to wait for when they when they have the necessary teams in terms of the work that lies ahead when they look at the actual outcome measurement set, because there are quite a number of things that you'd want to measure there. So just get started with what you have. And if there are senior people, make sure that they buy into the story and they give the full support in terms of ensuring that as you go forward, the necessary changes in the business are done, and they also avail the necessary resources to get started. I found that to be very key for the little that we've done so far. Over to you, Doc.
Yeah, so if I'm advising other organizations to see how they can tackle diabetes, I really would say they need to get buy-in from the patient themselves. They need strategies to get the patient involved and be very deliberate about it. So you really need to win the patient's heart and putting them at the center where they actually realize that we truly care and we are trying to make their lives better. Because with that buy-in, you get a lot of effort as well from the patient to push for their diabetes being better. As I mentioned, the lifestyle component is a big thing. And if you don't get that buy-in from the patient and the patient is not putting in the effort, you find that you have difficulties to control the diabetes, even when you've put everything in place. You won't like the results at the end. So we need to get buy-in from the patient. And so we need to have a heart-to-heart type of talk with the patient and try to win that kind of buy-in from them. So patient engagement is it's really quite important. And I know sometimes it's particularly difficult in our setup because of time constraints, where if it's a consultation, it's limited maybe to 20 minutes or so sitting with the patient. But for diabetes, it needs actually investment in terms of time to sit down for an hour with the patient and try to gain their commitment to the journey. So patient engagement is one of the key pillars to try and control diabetes for any organization that is tracking diabetic care.
That's fantastic. And I think a great note for us to end on. It certainly aligns well with ICHOM's mission as well. So it's been fantastic to hear your insights and, learn more about your implementation journey. And we thank you so much for sharing all of your insights with us today. That does unfortunately bring us to the end of our time for today's session. So I want to thank you once again for generously contributing all of your time today and for everyone who has joined us. I do want to show a couple quick announcements before we do end the webinar. So I do want to emphasize that we have recently launched our implementation directory. So for everyone in attendance today, if you are implementing our ICHOM sets, we ask that you please fill in a brief survey that you can access following the QR code that you see on screen here. And this is really for us to learn more about implementers globally who are using our ICHOM sets. And if you would be comfortable, you're also able to let others know about the fantastic work you're doing and about your implementation efforts. So by joining the implementation directory and the associated map, you'll have the chance to network with other implementers and build a community and learn from each other. So please do complete the survey to join that directory today, just to have that global recognition. And if you'd like to be featured at one of our upcoming webinars, such as Foster and Travolta, showcasing their fantastic work today, this will be a great way for us to get in touch with you as well. So the next session in the ICHOM webinar series will take place on Thursday, July 24th, which will be about Singapore's value-driven approach to better outcomes and cost savings in knee surgery. So if you'd like to attend that session, please do register on our website. That is, of course, again, free registration to attend, and we do look forward to seeing you there. Finally, I also want to make you aware of our value-based healthcare professional certificate program that Foster referenced a couple slides back. So ICHOM Education is a fully online course lasting 15 weeks. And you'll have the chance to learn about the how-to skills in value-based healthcare from leading implementation experts and network with a lot of like-minded and global peers in this space. So it's really a fantastic course, and you can register for our upcoming cohorts on the website link that's shown at the bottom of this slide. So with that, I want to thank Foster and Travolta once again for the fantastic session and for very generously sharing their time with us and all of the insights and learnings. I also want to thank everyone in attendance today for joining. I know for some people it will be very early, very late, so it was fantastic to have you all with us today. We hope you have a great rest of your day, and we look forward to seeing you at our next webinar. Thank you and goodbye, everyone.